think are going to be there if you ever want to eradicate TB, particularly from a setting like South Africa where we treated about 500,000 people in 2011 for tuberculosis. So clearly we have an enormous problem in South Africa, and I think ranked globally, South Africa is about the second by incidence and about the fourth or fifth by total number of cases. So, I'll take you through some of the ideas that I have about this. So, of course, the two epidemics, TB and HIV, are intimately linked. And you can see these are the two WHO maps that are shown for TB and HIV, and the darker colors are where there's more of each. And you can see that this overlaps in the sort of southern parts of Africa quite amazingly. And the other graph that I'm showing you here is this massive increase in annual TB incidence in the yellow line, which paralleled that of HIV prevalence in pregnant women. So the red line on the lower graph is every year in South Africa they do a seroprevalence, anonymous seroprevalence in pregnant women, and I've conjoined these two graphs to show you that how this HIV epidemic has really affected South Africa. And you can see that even before the HIV epidemic, South Africa had a terrible TB problem, which was then, as though petrol had been poured on a fire, suddenly rapidly increased over the past 10, 15 years. And this all, if you see the dates, the HIV seroprevalence really started to rise just as Nelson Mandela was released and South Africa became a new liberated country, and all these other things. So it really, along with the sort of liberation of South Africa, we have experienced this dreadful increase in HIV and concomitant TB infection. And this is just really to reinforce this. So you can see that on the left-hand side is a graph showing men and women. The men are in lighter shade, the women are in the darker shade. And on the right, in this black and white graph, are age annual incidence for a set of countries in sub-Saharan Africa, and you can see essentially that the age-specific annual incidence really parallels that of HIV prevalence, and this occurs in most of the sub-Saharan African countries adjacent to South Africa. So I guess that the main thing that one could do if you really want to eradicate TB in a setting like ours is eradicate HIV. And clearly there have been some massive advances in trying to prevent HIV. And the two things that have really show promise are firstly male circumcision, and secondly treating people with antiretrovirals at a very early stage, essentially at the time of diagnosis, to try and stop ongoing transmission. So there are three clinical trials done in sub-Saharan Africa which showed a similar effect of male circumcision. And recently the South African government started a male circumcision rollout, and in an attempt to try and prevent men, particularly young men, from acquiring HIV as they embarked on their sexual careers. And you can see PEPFAR, which is the US government funded initiative, has ensured that a lot of circumcisions have been done, but and certainly in the past you can see that it's really ramped up, and in the last quarter where we have data for 89,000 circumcisions were done in South Africa, but you can see only I think 6 out of the 9 provinces are listed here. So in South Africa, 3 provinces really don't have a circumcision program, even 2 years after we've started to roll this out. That's the first thing. The second thing is that if you do a sort of back of the cigarette box calculation of how many circumcisions should be done, you can see that even though approximately 600,000 circumcisions is a big number, we are way behind what we should be doing if we try to protect men. Now the other problem with male circumcision is that it really only protects men who are circumcised. It doesn't protect their partners. The hope is that in future years that these men who weren't infected won't infect their partners in the future. So at this time, there's still no evidence that it protects women, but certainly it does protect men. So as you probably are aware, as the previous speaker was talking about, the TB programs are all about control. They're all about trying to find TB cases and treat them. And you may or may not remember the WHO came out with this whole program of DOTS, directly observed treatment, short course, and there was some concern expressed that in high HIV prevalent settings that this wouldn't be enough to control the TB epidemic. And so recently the WHO came out with these 3 I's, and one of the I's is intensified case finding, which is essentially going out and trying to find cases of TB before they've had time to spread to other people, and before they've had time to develop morbidity and mortality related to their TB disease. So clearly, easily targeted groups that you could do this intensified case finding are people who are attending counseling, testing for HIV, pregnant women who are coming into prenatal or antenatal care, who are getting HIV tested as part of their routine care, HIV infected people, especially those who are about to start antiretroviral, and healthcare workers, and not so much in South Africa, but I'm sure in your sort of setting, immigrants are probably, especially the ones from high burden countries like South Africa or India or China, are tested for tuberculosis. So just one thing to bear in mind when symptom screening is done, and this may have a major impact on the transmission dynamics in a place like South Africa, is that people who are HIV infected have a very much abbreviated duration of symptoms. So if you're doing symptom screening to identify people with TB, then people with HIV will either die or they'll come into a hospital early because their TB is rapidly progressive. Whereas seronegative patients, you can see here, have a much longer duration of symptoms before they seek help from a healthcare provider. And so the theory that follows this this difference in duration is that in a place like South Africa, the people who are HIV infected are really bearing the brunt of morbidity and mortality, and the HIV seronegative patients are the ones that are doing the transmission. And I think this also has implications for curbing transmission, because in most instances, this intensified case finding or active case finding is done in HIV-infected people. And clearly there's a need to do it, but in terms of transmission, you really may have to be doing it in the people that are not coming to the HIV clinics, who are not testing HIV positive, but still have tuberculosis, which just makes it slightly more complicated. So then, clearly, if you do case finding for TB and hopefully find a case earlier than you would have under normal course of events where someone developed symptoms and they came to the clinic, but you go out and you look for cases, what do you do? So if someone is HIV infected, of course CD4 counts, start antiretrovirals. If they're HIV seronegative and they're male, as a matter of course, they should be referred in for a circumcision. Clearly, isoniazid preventive treatment, and I'll say a few words about that later. And for people who are tuberculosis skin test positive if they're HIV infected, and possibly there's a place to do it in people who are seronegative in a place like South Africa as well. And the other thing that is not frequently done in high burden settings, sort of paradoxically, I guess, is that there's not much contact tracing going on. So if someone is diagnosed with TB, clearly that would probably indicate, particularly for people who are immunosuppressed, that they've had a recent exposure to someone who's infectious, who's got TB at home. And contact tracing is something that I believe is important, and I'll talk about that just now. But I'll just give you some examples of intensified case finding where to show you the potential benefit. But TB in pregnant women has major implications both for the mother as well as for the fetus and for the infant, and it causes prematurity and it causes low birth weight, and the child can also have TB. And the other thing about pregnant women is that this is a group that will attend healthcare at some stage during their pregnancy, and it really offers an ideal opportunity to intervene and try and find out if they have TB. And certainly in our sort of settings now, these vertical transmission programs to prevent mother-to-child transmission of HIV are becoming quite developed. So not only do they do an HIV test, but they're able to do a CD4 count, and then based on the CD4 count, they're able to determine whether someone should get AZT or whether they should get antiretrovirus triple therapy. And so it's relatively easy to add in a TB case finding or intensified case finding program. So in Soweto we did this, and we did this as part of pre-test counselling. So as women came in and they were HIV tested, they were counselled. Sorry, they counselled before the HIV test. We asked them if they had symptoms of TB, and if they did have a symptom, if they did have any of the symptoms, any one of the symptoms, we then said, okay, we will take a sputum from you for smear culture. And you can see that in HIV seronegative, lab confirmed TB in about 0.2% of these women. Now that might look low, but I think I saw in this brochure that was handed out that in Barcelona the annual TB incidence is about 0.027. So this is 10 times what is happening in Barcelona currently in seronegative women, and in seropositive women about 0.7%. And this is just using symptom screening as a basis for investigation. So saying to women, do you have cough, do you have night sweats, do you have loss of weight, do you have et cetera, et cetera. And if they answer positive, then investigate them. But we then were concerned that, particularly in pregnancy, pregnancy may mask some of the classical symptoms of TB, particularly related to weight loss and possibly women having flushes and other things related to their pregnancy. So in another site that I work in, we tested everyone with a smear and culture, irrespective of whether they had symptoms. And we found much higher rates. You can see here, there was a total of 3.4% of these pregnant women had TB, and 2.6% of them were diagnosed by us. So there were some that were already on TB treatment, but in addition to those that already knew that they had TB, we diagnosed a further amount of women. And the real concern, I guess, is that a lot of these women denied symptoms of TB. Now, whether this is because they don't want to admit to themselves that they're HIV infected, plus they've now got symptoms of TB, or whether it is because there is such a thing as subclinical or asymptomatic tuberculosis, I don't know. So it could be contextual, it could be a clinical entity, it could be that they're in a continuum of their disease, and that if we tested them in 5 weeks' time or 3 weeks' time, they would have symptoms. But irrespective of that, it seems that this, if you do this sort of intensive active case finding, using a laboratory diagnostic to find cases, you're going to find more and more cases. Now this study wasn't so good for us because we used a midget culture, and as you're aware, the midget culture, if it's positive, takes about 2 weeks to get a result, and if it's negative, you've got to wait for a much longer time. And 2 of these women that we diagnosed as TB, by the time we got back to them, they had already died. So the TB that we see in South Africa is quite progressive, and it possibly may be that using a more rapid diagnostic modality like this gene expert for TB may be more appropriate, and a point of care test in situations like this, and it may benefit in preventing both transmission and morbidity and mortality. The other people have done studies in adults about to start antiretrovirals, and you can see there's a very high yield if you use a lab diagnostic, and in all of these studies they used culture, a midget culture. If you use a lab diagnostic at the time that people are starting antiretrovirals, and you get, 31% of heart initiators were culture positive in Cape Town. Almost a third of their patients about to start antiretrovirals have culture positive sputum, which I think is quite horrendous. Now, Cape Town, even within the whole gamut of South Africa, is quite an unusual place. The rates of TB are much higher than the rest of the country, and I think that you're probably seeing that, and no one is sure why. why is it that Cape Town has this sort of more exacerbated TB epidemic than the rest of the country? But Cape Town is different for a number of reasons. But in relation to TB, I'm not sure why that is. And it seemed the second thing about in the Cape Town study, it seemed that in the intensive case finding at heart initiation then prevented this TB iris, which is an exacerbation of TB as people's immune system starts to recover when they're taking antiretrovirals. So I guess the other thing that one could do if you wanted to eradicate is to start providing preventive treatment regimens. And certainly a lot of interest has been given to giving preventive treatment to HIV-infected adults. And I think that you heard that internationally the trend is to try and shorten TB treatment regimens. And paradoxically, in our sort of setting, giving longer preventive treatment regimens is actually more beneficial to people than giving shorter regimens. And it might be that the force of reinfection is so high that, that people need to be receiving, much like you give cotrimoxazole to prevent pneumocystis and other bacterial infections, so you should be giving isoniazid on an ongoing basis, on a continuous basis, to try and prevent people with HIV from getting active tuberculosis. And the graph on the right is done by Taraz Samandari from the CDC in Botswana. And the red line is tuberculin skin test positive patients who received 36 months of isoniazid, and very few of them developed TB. The other three lines are the TST negative patients who received this long-term treatment, as well as the control group who just received 6 months. And you can see that the rates of TB started to rise very soon after the initial 6 months of treatment that they all received. So the long-term, and similarly, this is on the left-hand side, the graph there shows work that a randomized trial that we did in Soweto, where people were randomized either to receive long-term isoniazid preventive treatment or the shorter arms, and the solid graph remaining below is this INH continuous. So it seems that that giving people INH continuously is probably a good thing, particularly for HIV-infected individuals. Whether it's a good or a bad thing for other people is not known. And interestingly, another study was done in minors by Gavin Churchyard from the Aurum Institute, where he showed similarly that if you give mass isoniazid preventive treatment, it appeared to have no beneficial effect on minors. And minors in South Africa, particularly gold miners, are another one of these slightly weird populations. So for South Africa as a whole, the annual TB incidence is approximately 1,000 per 100,000. In gold miners, it's about 4,000 per 100,000. So about 4% of gold miners are getting TB every year. So 4,000 per 100,000. I mean, it's incredible rates. And in that population, Gavin did this cluster randomized study where clusters were randomized either for minors to receive IPT, irrespective of whether they were HIV infected or not to receive IPT. And he showed that there was no benefit in giving this mass preventive treatment. And so people jokingly refer to, well, we put isoniazid in the water. But it appears that even if you try to do this, it doesn't really have a major impact in reducing rates of TB. The one thing that they did find in that study is that while the minors were taking their TB, their isoniazid preventive treatment, they were protected from TB, much like we found in our study and Taraz found in Botswana. That it seems that if you're HIV infected in this in these settings where there's incredibly high pressure of infection, that you need to take it for a long time. Now, of course, there are issues of resistance and other things, but I guess that for the purpose of this talk, our prime discussion is about eradication. The other thing that we've looked at is contact tracing. And sorry, this slide doesn't project very well, but essentially what we did is we went to houses of people who had been diagnosed with tuberculosis, either in the hospital or in one of the clinics. and we went to do contact tracing. Now, contact tracing in our setting is not usually done. In the US and other places, I think in the US it's been, they have obsessively followed this idea of contact tracing, and certainly their rates of TB are coming down dramatically. And in part, I'm sure it's due to this sort of obsessive follow-up. I mean, it's almost like we in South Africa would treat a case of Ebola virus. They, in America, they would treat an index case of TB. So we just restricted our investigations to household members of an index case of TB. And you can see that if you look at the total TB line, you can see in the contacts of an index case, 7.6% of them had TB. Whereas in randomly selected households, so we used Google and we worked out coordinates and we randomly selected households. And in those randomly selected households, only 0.4% of them had TB. So 0.4 is still a relatively high figure in the in the European sense, but compared to the index cases, it does appear that targeting households with by virtue of the fact that they've had an index case diagnosed in the health system may be a way to identify either transmitters of TB and or other people who have TB in the household. And this has been recently shown in this massive study funded by the Bill and Melinda Gates Foundation done in Zambia and South Africa, where communities were randomized to receive either this active case finding in the households or upgrading of the clinic case finding or community case finding. And they found that this household evaluations appeared to show, unfortunately, the two outcomes that they used, the results unfortunately overlapped one, but it seemed that if you look at these two outcomes, which was looking at the impact on TB prevalence in the community, as well as looking at tuberculin skin test in little kids, that this contact tracing was of some benefit in these communities. And I spoke to one of the PIs of the study just as I was coming here, and she said that by looking at the data slightly differently, they may be able to show that it was statistically significant. But you can see first of all, the relatively small benefit that you find by pouring these resources into these contacts. And secondly, even by having this massive study with, I think they had 18 communities which were randomized, they were unable to show a significant benefit. So eradication, I think, is somewhat problematic. Now, it may be that eradication is quite difficult because there are these reservoirs of infectious and undiagnosed TB. And firstly, I spoke to you about asymptomatic or subclinical TB, and I'll talk to you about death and of course the latent TB, which others have referred to. So firstly, this asymptomatic or preclinical TB. So in this study that we did in pregnant women, we found that 28% of pregnant women who we found were culture positive reported having symptoms of TB. Another study that I found was in Ethiopia, where 15% of TB cases that they diagnosed at a voluntary counseling and testing setting had TB. And of course, that study from Cape Town that I referred to earlier, where 18% of those who were sputum culture positive reported having no symptoms. In that study, they went back to these patients to tell them of their positive results, and 10 of the 16 that were asymptomatic had by then developed, were then reporting symptoms of TB. So I think that this has quite major implications that if there is any move to do community-based screening by symptoms, which is currently what the WHO is recommending for HIV-infected people, then you're going to be missing a lot of people who are potentially infectious. So if you just use symptoms to try and identify those that are infectious, you're going to miss a reasonable proportion, and probably depending on the context and depending on who you're targeting, you're going to be missing some infectious patients who are still continuing to cough up infectious material. The other thing that I think is of some importance is that if you look at death certificates in South Africa, tuberculosis is now the leading cause of death. Now clearly, it shouldn't be tuberculosis in some of these death certificates. It should probably be HIV. And there's misclassification because there's some bias by the families. They want tuberculosis on the death certificate rather than HIV, or the doctor is reluctant to put HIV or something. But anyway, using the death certificates, TB is recorded as the leading cause of death. And this in a country which has multiple other leading causes of death, potential leading causes of death. We have very high rates of interpersonal violence. We have very high rates of other problems. But TB is the leading cause of death. However, the same report says that about 30% of deaths occur at home, number one, and over a quarter of the deaths of the death certificates have a poorly defined cause of death. So, for example, the cause of death might be cough or low hemoglobin or something that you can't categorize it according to ICD-10. So we did a study in the study site in a mining area where we went to mortuaries and we found out those people who died of an apparent unknown cause. So people who weren't stabbed, who weren't run over by a bus, who hadn't been admitted to hospital recently, who didn't have a diagnosed lung cancer or some other apparent cause of death. And so these were people where there was no clear cause of death. And we did a true-cut biopsy in both of their lungs, and we did a modified bronchoalveolar lavage. So in the corpse, in the mortuary, this is what we did, and we asked the family, after getting consent, we asked them about some of their symptoms. And we found that 29% of these people who apparently had no cause of death had infectious pulmonary TB. Which I think is of major concern, because these people, as they're getting ill, they're being looked after by relatives. I presume someone is turning them, someone's feeding them, someone's bathing them, doing that sort of stuff, getting very close. And if they have infectious TB, then clearly this is a major problem. And these are people that are not counted by either the vital statistics record, and they're not being counted by the TB control program. So for me, this is of concern. The other study was done in a hospital in KwaZulu-Natal, where they did a similar study design, and they found that 50% of all the cadavers that they sampled had evidence of TB. And so some of these patients were already on TB treatment. But of those not on TB treatment, and I think they used not on TB treatment as a proxy for undiagnosed antemortem, those not on TB treatment, about 42% of them also had TB that had been undiagnosed prior to death. So clearly, if you start adding up these numbers and applying them to the total mortality in South Africa, these will add to the number of TB cases and the opportunities for transmission to carry on in the absence of treatment. Similarly, in people starting antiretrovirals. So in South Africa has the biggest antiretroviral program in the world, and about 1.6 to 1.8 million people have been started on antiretrovirals. And I think that the mortality rate is, for people starting antiretrovirals in our sort of setting is about 15%. And so of those who die, you can see a large proportion of them will have undiagnosed TB. So people who haven't been diagnosed ante-mortem to be having TB and haven't been started on treatment. So again, some concern about undiagnosed tuberculosis, and particularly important unless you have an effective vaccine, of trying to eradicate TB. And then of course latent tuberculosis. So I was telling you about Cape Town, which has this sort of somewhat unusual epidemic even for South Africa. And this is work done by Robin Wood's group, and really it just shows the force of infection and how in the adolescent years, rates of tuberculin skin test positivity rapidly rise. And he postulates that it's because kids are starting to go out of the household and being exposed to a much larger pool of potentially infectious people, that's why you have this rapid rise in the adolescent years. But it never gets quite to 100%, and it sits at about, once people are adults, it seems to sort of stabilize. But I think this illustrates the very high rates of latent TB infection in populations in South Africa. So thank you very much for your attention.